It's Angie, and hey, everybody. Thanks for joining us today. So we're going to take a dive into neurotransmitter testing and how you can use that data to help support your patients. So let's start with the definition, just so we're all on the same page. So we know that neurotransmitters are chemical messengers, and they regulate emotional and physical processes, things like movement, the stress response, pain, cognition. They largely focus in the central nervous system, but also in the periphery to facilitate communication between the brain, the body's glands, organs, and muscles. They're usually considered chemical messengers that move between neurons, but they are located elsewhere in the body too. So, for instance, if serotonin is secreted in the gut, we still call it a neurotransmitter. So neurotransmitter testing can lead to successful treatment interventions for a variety of health symptoms. We think about mental health, of course, anxiety, depression, trouble with focus, things like that, but also more physical symptoms, chronic pain, headaches, IBS, weight issues, fatigue, cravings. One of the things I love most about it is that I feel like it can help me determine the correct treatment for some of the symptoms I see very frequently in my practice. So I don't know about you, but I feel like it's ubiquitous that my patients are having issues with mood, so depression or anxiety. They're tired, they're not sleeping, and they can't focus, right? It's pretty much everyone. So this testing really helps me because we know that while antidepressants are widely used, they're not always helpful. But you can see here, this is representative of a survey between the years 2015 to 2018 that found that antidepressant use increased with age, and it's twice as common among females as males. And about a quarter of the people who had reported taking antidepressants in the previous month of the survey said they'd taken them for 10 years or more. And this was before the COVID-19 pandemic, because when COVID hit, prescriptions went through the roof. You can see here that there was a 21% increase in prescriptions for insomnia, depression, and anxiety just in the first couple of weeks of the pandemic. And this really hasn't changed a whole lot in the years since. But despite these drugs being commonly prescribed, they don't always work better than placebo. This was a study from 2008 that found that paroxetine, fluoxetine, and venlafaxine worked no better than placebo. So it was a meta-analysis, an additional meta-analysis from 2011 reported that the relapse rate among depressed patients given antidepressants was between 42 and 57%, but the relapse rate for those given placebo was only 25%. This is just the stats. We do know that depression can be associated with things besides serotonin, and this was looking at SSRIs, but still something to consider. So if antidepressants aren't always working as well as we'd hope, what can we do? I did want to point this out. As of June 2023, the United States Preventative Services Task Force recommends screening for anxiety disorders in asymptomatic adults who are 65 years old and younger, who don't have a diagnosed mental health disorder. So this essentially means you should be screening everyone under 64 who comes into your practice. They also recommended that clinicians screen all adults of all ages for major depressive disorder. So I just listed here some of the screenings that you could consider for anxiety and depression. So the challenge here, now that it's recommended that we screen everyone, is that if you find your patients are experiencing depression and anxiety, they need to be evaluated further and they need to be supported. And there is a very significant lack of the numbers of mental health support providers who offer mental health support currently. People are having trouble finding providers who have room in their schedules. So our patients are suffering and there's a lack of resources. So we, functional medicine docs, can do so much to provide support. And so that's what I want to talk to you about today. So often when I think about where to begin with these patients, I was sort of trained in the neuroendocrine realm. So I consider these first. And neurotransmitters, now that I'm able to test for them, have become really important consideration when I'm thinking about treating patients who are dealing with some of the symptoms we've talked about today. So when it comes to urinary neurotransmitter testing, we often get this question, which is really a criticism. People asking, does this neurotransmitter testing measure brain levels? That's a common criticism that it doesn't. And it does not. The answer is no, it doesn't. It screens whole body levels. We also had this question submitted in the registration process. Are there randomized controlled trials that show the benefit of neurotransmitter testing? And not that I've been able to find. But I'll tell you this. I screen for neurotransmitter imbalance with this urinary testing with all of my patients who are dealing with anxiety, depression, cognitive challenges, insomnia, issues with focus, etc. I use this test. This has been available in the United States for decades, but it's still a new tool to a lot of practitioners. This idea that it's not valid because it doesn't measure brain levels of neurotransmitters, I think, is probably a little bit of a misguided question or criticism. We know that neurotransmitters are secreted most often in between neurons, but they're secreted in the peripheral nervous system as well as the central nervous system. And we're not able to measure what's in the synapse, what's in the CNS, unless we do a spinal tap, and that's just too invasive for regular clinical practice. So this urinary testing allows us to get an idea of what whole body secretion is, and it really does correlate well with symptoms. You know, we often focus on serotonin with our treatments. SSRIs are a primary example, but we know that up to 90% of the serotonin our body secretes is outside of the CNS. It's in the gastrointestinal tract. So, you know, we think about the activities of things like serotonin and even the stress catecholamines, epinephrine and norepinephrine, they're all secreted in the periphery, but they have a lot of central activity. There are receptors for dopamine and glutamate and GABA in all the tissues of the body, not just the CNS. And we also are learning more and more about how much peripheral activity can affect the way that we feel, like our microbiome actually secreting neurotransmitters. So I have found that this neurotransmitter testing really does give me a good idea of the imbalances my patient is dealing with and how I can utilize targeted treatments to help them. So here's a lot of research if you want to read more. None of these are double-blind, randomized, placebo-controlled trials, but a lot of these trials are using mass spec to test neurotransmitter imbalances that can guide treatment. Okay, so we're going to start by talking about some general treatment concepts. Typically, that's why you guys come, right? Because you want to know how to help your patients. So while our minds are fresh, I'm going to speak through some general concepts, and then we'll go through the neurotransmitters one by one and speak about how to be a little bit more specific in terms of addressing those imbalances. So here is a biochemical chart that shows you the conversion steps involved between turning an amino acid precursor into the neurotransmitter in question. So you can see, for instance, this is the serotonin pathway. Tryptophan is the amino acid that turns into 5-HTP, which turns into serotonin, and that eventually becomes melatonin. So just to orient you there, all of the enzymes that move these changes are here on the right in blue, and the cofactors are on the left in orange. So this helps you, I think, get oriented when thinking about how to support patients. And also, I actually keep this on hand to use it as an example when I'm talking to my patients about why I'm choosing therapies. You know, if I'm choosing 5-HTP for a patient, this allows them to see why, because it supports serotonin. And this pathways chart, by the way, is released as part of every neurotransmitter profile. So you'll always have it on hand. So after you've evaluated neurotransmitter levels, generally the first therapeutic that we think of is amino acids, because these are the precursors required for making neurotransmitters. So I generally think about amino acids, and then I think about the cofactors that help to fuel the enzymes that move these biochemistry pathways. And then I also consider botanicals, generally nervines and adaptogens that can help support these processes. So the amino acid precursors are things I'm sure you're aware of, things like tryptophan, tyrosine, etc. Some of the biggies are listed here in this chart. I have found it's generally a little bit more effective to take them on an empty stomach. My colleague Brandon Lundell, I've heard him say it's better to have it in the body than in the bottle. So, take it. If you've eaten and only then do you remember to take it, take it. That's what's important. But if an empty stomach is possible, the body seems to absorb it as a bolus and utilize it a little bit more efficiently that way. Many of these can cross the blood-brain barrier and interact with the HPA axis and help to regulate neurotransmitter secretion and metabolism. And generally, you'll also be giving some cofactors to help to support the imbalances. Adaptogenic herbs can help the body resist and adapt to stress. They are often thought about with HPA axis health, but they can also contribute to neurotransmitter balance. Officially, to be called an adaptogen, the herb has to enhance physiology without having any notable adverse effects. Generally, these herbs are pretty gentle. They can promote optimal hormone and catecholamine levels, whether they're high or low. They kind of have a modulating effect because they promote balance to the entire adrenal gland. So while cortisol is released from the adrenal cortex, neurotransmitters like epinephrine and norepinephrine are secreted from the adrenal medulla. Nervines can also be really helpful, especially if you've got some excess excitability. You can give them as teas or tinctures or extracts or capsules. I generally think of these for symptoms like stress, anxiety, insomnia, and even mild depression. Mucuna pruriens is an herb that you'll want to be familiar with. It has been used for centuries in India to help manage Parkinson's because it actually contains small amounts of L-Dopa, which is a precursor to dopamine. And so you'll often see it as part of nutraceutical formulations that also contain tyrosine, which is the amino acid precursor of dopamine. And then I wanted to speak quickly about St. John's wort because it's one of the most well-researched herbs in terms of mental health. It has been shown in a lot of studies to provide equivalent relief of mild to moderate depression when compared to SSRIs. So this can be a good treatment option for depression. I do want to remind you to use it with caution, though, because it's metabolized via some common cytochrome pathways. And so there are some medications that it can interact with. One is oral contraceptives, which are pretty commonly utilized. Now, L-theanine is an amino acid that you're going to want to remember, and you're going to see it come up again and again as we move through this lecture. L-theanine is found almost exclusively in the tea plant. It can be used to treat both high and low neurotransmitters. It sort of acts as a modulator. Think of it kind of like an adaptogen. We know that it has a lot of functions. It can act as a GABA agonist. It can have antagonistic effects on glutamate receptors, and it can even modulate levels of neurotransmitters like serotonin and dopamine. You can see here it's got a pretty wide therapeutic range. Giving it twice a day is generally recommended because it does have a shorter half-life than some of the others. It's very calming. It can boost alpha waves in the brain, which are calming, but it can also help to improve focus and cognition, especially when it's combined with caffeine, which is in its natural form in the tea plant. Meditation is a really powerful treatment. If your patients aren't yet dabbling in this, you might recommend they try some of the apps, which is a good way to get started. Things like Calm and Headspace. There are a million out there. But regular meditation is associated with higher serotonin levels, lower norepinephrine levels, can help modulate dopamine, GABA, and even melatonin levels have been found to be higher the evening after someone was meditating. So now we're looking at this biochemistry pathway through the lens of cofactors. So remember, if we think about each biochemical conversion here, the enzyme is on the right, the cofactors are on the left, and the cofactors are necessary to fuel the enzyme's action. So let's take this as an example. If we're looking at the conversion of norepinephrine to epinephrine, say you got your neurotransmitter results and norepinephrine was elevated and epinephrine was low. That would indicate that this enzyme, the PNMT enzyme, is sluggish. It requires the cofactors SAMe and cortisol. It's a methyltransferase, which is why SAMe is a methyl donor. And it also indicates you may want to consider looking at HPA axis health and testing cortisol for this patient because cortisol is necessary to fuel that conversion. So in times where you see this it's almost like there's a dam building up here. You've got a lot of the substance before the blockage and not a lot below it. We think about this enzyme being sluggish and how do we use cofactors to help support the movement of that enzyme. Now, generally, when you're using cofactors, you want to use the activated form so that there's no barrier to usage. The body can just utilize it. So say vitamin 6, that would need to be in the form of pyridoxal 5-phosphate. If you're giving some of the B vitamins, folate and B12, you want to make sure they're methylated. It just helps increase efficiency and the likelihood of response to therapy. Methylation is a really important consideration when we think about a lot of aspects of health, but certainly neurotransmitter health is one of them. Methyl tetrahydrofolate reductase is the name of both the gene and the enzyme that plays an essential role in processing folate. And methylation affects a diverse variety of metabolic processes. And then when it's disrupted, you see disruptions in physiology. And in this case, we're talking about neurotransmitter imbalance. So a couple places where it really becomes important. Anytime there's a methyltransferase, obviously that requires a methyl donor, but the rate limiting step for serotonin and dopamine creation is this hydroxylase enzyme, tryptophan and tyrosine hydroxylase. And you can see here that one of the cofactors is BH4. This is tetrahydrobiopterin, which is methyl dependent. So really important for mood regulation. It also comes into play when we think about how homocysteine transforming into methionine requires a methyl donor, and then methionine is converted to SAMe, which then acts as a methyl donor for all of the monoamine transmitters. And here's some ideas of how to support it. Of course, that's up to you. We all have different styles. SAMe tends to be a little spendy, so sometimes methylated B vitamins is a good place to start. So many of these neurotransmitters require methylation to be made. We think about the catecholamines plus serotonin plus glycine. Epinephrine here is in italics because I have seen patients where all of these neurotransmitters are low except for epinephrine. And I think the body prioritizes the stress response above other things. And so sometimes we'll see epinephrine continue to be elevated when all the others are low, even in patients that we know have a methyl defect. So keep that in mind. You know, people who have issues with methylation typically are able to methylate to some degree. It's just typically a little slower than people who don't have issues with it. Vitamin D is an important cofactor to consider because, again, thinking about these cofactors that move this first step from tyrosine and tryptophan into serotonin and dopamine, we can see that vitamin D here is a cofactor. So it affects the rate limiting step of these neurotransmitters. And please advance. There we go. Fish oil, important. It's not a cofactor, but I did want to mention it because it benefits the nervous system. There's two major components. We know that they're EPA and DHA. EPA is more of the anti-inflammatory component, and DHA contributes to the fluidity of cell membranes. It plays a vital role in the structure and function of the brain, and it's a significant component of nerve cells and myelin. Fish oil is neuromodulatory and can exhibit antidepressant effects. The microbiome also should be considered. We know now that alterations in gut microbial composition are associated with changes in behavior that are related to mood and pain and cognition. And dysfunction of the microbiome gut-brain axis is implicated in all sorts of issues that we might think of as mental health. But also things like IBS and even autism, which is considered, I guess, a syndrome or a disorder, but likely has some contributions coming from dysbiosis. So with each year that passes, we get more and more data about how the microbiome can affect neurotransmitter secretion and issues like depression and anxiety. So certainly thinking about maintaining a healthy microbiome is helpful. You can do that with diet, but you can also sometimes consider probiotics. And this is an interesting study looking at this particular formulation of lactobacillus and bifidobacterium. They were looking at rats and human subjects. The study found that probiotics can attenuate anxiety and depression in experimental animal and human models. Evidence suggests that oral probiotics may have beneficial consequences on mood and psychological distress. And the authors proposed 3 mechanisms for this: competitive exclusion of the deleterious gut pathogens, a decrease in pro-inflammatory cytokines, and also direct communication with the CNS via the vagus nerve. All of these proposed mechanisms can affect neurotransmitter secretion. And now there are actually ways to determine the makeup of the microbiome with PCR testing, which can be very helpful. So this is an example of the first page of the GI 360 stool analysis that includes assessment of the diversity of the microbiome and specific details on levels of pathogens and beneficial bacteria. So this kind of testing can be really helpful, especially if you have a case that's proving to be difficult to treat. And there's some resources for you. So I want to take a few minutes to talk about inflammation. Not every depressed person is inflamed, but inflammation is a common avenue to depression, and you really need to consider it when you're trying to determine the root cause. So here on the left, you can see that this was information taken from Psychiatric Times, and they're listing some common factors that can contribute to inflammation. Obesity, being sedentary, not sleeping, ACEs, illnesses, infections, etc. We probably should add here things like smoking, poor diet, things that we know can contribute to inflammation. But you can see that inflammation can result in a lot of imbalances that drive depression and anxiety. Inflammation causes inflammatory cytokines to be secreted. Once these cytokines cross the blood-brain barrier and reach the brain, they have the capacity to influence the synthesis, release, and reuptake of neurotransmitters like serotonin, dopamine, and norepinephrine. And more research supports the idea that depression, while it is a disease in itself, may actually be a symptom of inflammation. Inflammation can affect neurotransmitter metabolism, neuroendocrine function, and neural plasticity. So if you suspect there's inflammation, where do you look for it? And I loved this paper because it gave me sort of a roadmap of how to find it. The title of the paper is, so depression is an inflammatory disease, but where does the inflammation come from? Being able to identify the inflammation so we can address it at the source is really important whenever you can find it. So some places that you should be talking to your patient about and looking for inflammation are things like psychosocial stressors, poor diet, physical inactivity, obesity, smoking, altered gut permeability, atopy, dental caries, poor sleep, and vitamin D deficiency. And again, from the Psychiatric Times, we have ideas about considering inflammation. You know, they recommend things like not using an SSRI as first line and implementing lifestyle interventions, weight loss, exercise, sleep hygiene, etc. So these are not new concepts, but not all practitioners think through them. So when it comes to testing for neurotransmitter imbalance, there are 2 profiles that Doctors Data offers. The first is a Neurobasic profile. You can see here serotonin, dopamine, norepinephrine, epinephrine, a calculation of the norepinephrine to epinephrine ratio, glutamate, GABA, glycine, histamine, phenethylamine are all reported. Creatinine is reported, but this is just to assess the how dilute or concentrated the urine is. It's not diagnostic in any way. So if we haven't talked through the neurotransmitters at all yet, but based on what we've already discussed, what might you consider being an influence on imbalances like these, where we have low levels, pretty predominantly with one elevation here, I would certainly consider a methylation issue because serotonin and the catecholamines are low, and also inflammation, right? I think we should probably consider inflammation in all of our patients. So now I'm going to get into a little bit greater detail about how to support each neurotransmitter if it's high or low. And we'll start with serotonin. We know that it's biochemically derived from the amino acid tryptophan. It's primarily found in the gastrointestinal tract, and the remaining 10 to 20% is in the platelets and the CNS. Some of the symptoms you might see with imbalanced serotonin, and I just want to tell you these are not exhaustive lists. Somebody gave me feedback once that something their patient was experiencing had not been on my list, and so this is certainly not exhaustive, but these are some of the things you might see with imbalanced serotonin. We know that it's involved in depression and anxiety, but also really intricately involved in things like hot flashes and night sweats, some of our aches and pains, or even bowel and bladder issues, because so much of it is secreted in the periphery. You might see insomnia because serotonin is the precursor to melatonin. You may see racing thoughts, emotional numbness. So there's a lot of things associated with serotonin imbalance that we might expect to see. Now, I do want to quickly note, because this is a common question we get, what equals depression? And it's very difficult to say. Take a symptom, put it in your head, whether it's anxiety or issues concentrating, whatever it may be, something you see a lot in your practice. I want you to keep it in your mind as we go through these, because you're going to see that a lot of imbalances can result in the same symptom, which is one of the reasons why I like testing so much. Now, appetite change is a really common thing to see with imbalanced serotonin levels. Generally, people are very interested in eating sweets and carbs. Sometimes you can see a lack of appetite, but more commonly what people seem to have is cravings for carbohydrates, and often sweet or salty carbohydrates. And the brain is trying to use these sweets to increase serotonin. So it's sort of self-medicating behavior. So low serotonin triggers this urge to eat these carbohydrate snacks, which can allow us to raise serotonin at least for some small amount of time. So you're going to see a treatment slide like this for every neurotransmitter we discuss, but I'm going to walk you through this one for serotonin, and then the rest of them we'll just sort of quickly touch on. So for each neurotransmitter, we'll give you ideas about supporting that neurotransmitter if testing reveals low levels or if testing reveals high levels. When we've got low levels, generally we're thinking about what comes above serotonin in this biochemical pathway that can help support it. Tryptophan or 5-HTP are great options. Rhodiola as an herb at lower potencies acts as sort of an adaptogen and can help to raise serotonin. Melatonin actually is a treatment for low serotonin, even though it is later in the pathway, and I'll touch on this a little bit more on the following slide. L-theanine acts as a modulator, sort of an adaptogen, so you'll see it often recommended when levels are either low or high. And then cofactors are important when we think about what's needed to fuel these enzymes. Iron is needed. Now, a quick note about iron. If your patients aren't iron deficient, giving them extra iron probably is not going to help this enzyme work better. But if you do have an iron deficient patient, and of course this is much more common in menstruating women, giving them iron supplementally can certainly help support the activity of this enzyme, but also vitamin B6, vitamin D, BH4, that tetrahydrobiopterin, which is a methylation factor, and here's some other things that go into the making of BH4. Now, if you tested and found that your patient had high serotonin, again, we think about theanine because it modulates, it adapts. Rhodiola at very high potencies has actually been shown to suppress elevations. And then cofactors that can help us metabolize. So we'll get to these enzymes that metabolize at the end of the lecture here, but for serotonin, we know that the MAO enzyme is fueled by some B vitamins as well as iron. So these are all considerations to support serotonin. Now, in the registration process, somebody submitted a question about the safety of boosting serotonin in a patient who is currently using an SSRI. I think it's a great question, and I just wanted to quickly touch on it. I think you can safely do this, and I've done this many times, if you test first to ascertain what the serotonin level is. If it's not elevated, I feel you can safely boost serotonin. But of course, you want to talk to your patient about what serotonin syndrome would look like. So that's the perceived concern. If a person is using a selective serotonin reuptake inhibitor and then you boost serotonin, could you create a situation where the patient had too much serotonin available, which could result in serotonin syndrome, which would be the most significant outcome? That looks like agitation, restlessness, confusion, disorientation, anxiety and insomnia, and even vomiting. So in your PAR-Q, you could certainly tell patients to keep an eye on that. But if you've tested first and you find serotonin is low, there's very, very little chance that you're going to induce serotonin syndrome in someone using an SSRI. So you can see here again, we have this biochemical pathway. Serotonin becomes melatonin. And often 5-HTP is given in sleep formulations and things because it can help to make more melatonin. But it was interesting for us to observe as we saw these neurotransmitters reports coming through that people taking melatonin as a supplement seem to have higher levels of serotonin. And it turns out there seems to be a bidirectionality in this pathway. So supporting serotonin can increase melatonin secretion, but also giving melatonin supplementally is a way to support lower serotonin levels. All right, moving on to dopamine. Dopamine is involved in the reward response, especially if the reward is perceived as greater than expected. So an analogy I like to use with my patients is put yourself into your little childhood body, and your parent gave you a quarter to put in the gumball machine, and you turn the crank and one shiny red gumball dropped into your hands. That was always an exciting moment, but you expected the gumball. But did you ever have the experience of putting the quarter in and turning the crank and having two gumballs drop into your hand? That surge of excitement that you felt, that is driven by dopamine because that reward was larger than expected. Dopamine stimulates pleasure centers. It enables us not only to see the reward, but to take action to move towards it. Motivation, it really is considered the neurotransmitter that drives motivation. Behavior and cognition, sleep, mood, attention, learning, etc. Locomotion and coordination of movement is important because we know that dopamine is involved in things like Parkinson's disease. So as a family, dopamine and its two downstream neurotransmitters, norepinephrine and epinephrine, are known as catecholamines. And also quickly, if you're not in the United States, you probably call these noradrenaline and adrenaline. Same compounds though. So what does excess dopamine look like? Things that once seemed safe and comfortable no longer do. You might see increased worry, paranoia, ADHD, a decreased ability to interact socially, and a desire for instant gratification. And if dopamine is deficient, we can see mood swings. We can see those feeling isolated because people don't have the motivation to get out to the world and try to connect with people. Those issues with motivation can manifest in a lot of different ways. Not wanting to connect with people, not being able to finish tasks, even not being interested in sex. Forgetfulness, we can see. And then there's some pathological states associated with dopamine dysfunction. Parkinson's is probably the most well understood, but also restless leg syndrome, ADHD, autism, schizophrenia. There are a lot of associations in the literature. Now, remember with serotonin, people can self-medicate by reaching for carbohydrates. When dopamine is low, people may self-medicate by engaging in behaviors that can create a sense of excitement and give them a reward. And often that can lead to addiction if it's left unchecked. So these people are a little bit more sensitive or prone to addiction for to things like food, drugs, sex, or gambling because they don't have enough dopamine, and engaging in these activities causes a transient increase in dopamine, and that feels good. But in the long run, it's not the best way to manage it. Dopamine is sometimes called the motivation molecule. Lab mice that are dopamine deficient are so apathetic, they will literally starve themselves to death, even when food is readily available. That's how important dopamine is to motivation. So here's some ideas about supporting dopamine if it's low or high. So we won't read through these anymore, but these are here for your reference. Massage, it's not just about your physical health or your back pains. We can see here that there's some studies that show that massage is good for managing cortisol and neurotransmitters like serotonin and dopamine. And I can't imagine any of our patients who come in with the symptoms we might associate with neurotransmitter imbalance not being thankful for a prescription for massage. Now, dopamine can be converted into norepinephrine, and that then in turn becomes epinephrine. These work together to control the fight or flight response. So increases attention and arousal, helps to regulate our heart rate and our blood pressure, and release glucose from energy stores. Norepinephrine is, well, both of these are released by stress, but norepinephrine is released both in the central nervous system and the periphery, largely in the central nervous system from the locus coeruleus, but also in the periphery, and that's where epinephrine is synthesized from the adrenal medulla. So again, the cortex is where we make cortisol, and in the adrenal medulla, we make epinephrine. So ACTH is secreted, in our brains to stimulate the adrenal cortex to release cortisol, and that in turn enhances epinephrine synthesis. Mostly epinephrine is a peripheral neurotransmitter. And then, of course, they work together to coordinate that fight or flight response. We can see, the most important part of the stress response is getting fuel to our muscles. So the degradation of glycogen and triacylglycerol is paramount, but then also the increase in blood pressure and cardiac output. So we talked about serotonin, people self-medicating for serotonin, maybe reaching for carbs. People self-medicating when dopamine is low by engaging in, what might be considered risky behavior or behavior that can give you a great reward. So what do these people have in common? These people are what we might call an adrenaline junkie. When catecholamine levels are low, these people might turn to essentially adventure sports because that fight or flight response gives them that surge in adrenaline, aka epinephrine, that gives them the high that they were missing. So let me quickly say this about adrenaline junkies. I'm not trying to say all of you out there have something wrong with you. Of course not. It's great to want to engage in exciting things. But the question becomes, if you find that you really are not feeling alive until you're engaging in, activities like this that cause this adrenaline spike, that might be when someone would consider intervening and trying to support you in additional ways. Catecholamines are excitatory. So that means if we have low levels of norepinephrine and epinephrine, we may see symptoms that would be associated with sort of like a depressed state, poor attention and memory, decreased concentration, brain fog, reduced socialization, right? That motivation isn't there, loss of alertness, depression, pain, lack of arousal and interest. Now, conversely, because these are excitatory, if we have elevated levels of these catecholamines, we may see physical symptoms like tachycardia, palpitations, arrhythmia, just that restlessness, even hypertension. And on the mood side, irritability, agitation, anxiety, can't focus because your thoughts are so racing, and inability to fall asleep, things like that. Overstimulated, essentially. And so some ideas about supporting norepinephrine and epinephrine are here. So now we're going to talk about the norepinephrine to epinephrine ratio and how that is associated with cortisol. So this ratio is reported on every neurotransmitter report, and it essentially is looking at how much norepinephrine is being converted into epinephrine. So you can see here, we've got a lot of norepinephrine. We don't have a lot of epinephrine. So this enzyme is not working efficiently. We have to consider the cofactors that fuel it, SAMe and cortisol. So HPA axis testing is always recommended if your NE ratio is elevated. And that's because cortisol and epinephrine and norepinephrine work together to mount the stress response. So I'm going to walk you through sort of 3 phases that I feel like I've identified over time. And it can be really important to test because patients can present with the same symptoms. Again, you could have 5 patients in front of you. They're all tired. They're all depressed. They're all anxious. They can't focus. They can't sleep. But these patients may all find themselves at different places in the stress response. So this is what I call early or phase 1. Generally, you'd see elevated cortisol and elevated catecholamines here. In these early stages, what we typically think about is trying to help provide resilience to the body and potentially squash what is sort of a hyper response to cortisol. So at this point, the body is still able to mount these very these efficient responses to stress. But as we know, when chronic stress continues over time, the body sort of loses that resiliency and loses the ability to respond to stress in such an efficient way because the sympathetic nervous system is not designed to stay in that high stress mode continuously for months and months or years. Some people call this adrenal fatigue, but that phrasing is really outdated. What we're really talking about here is HPA axis adaptation, right? Nothing's really fatiguing. The body's just adapting to this constant onslaught of stress. So at this point, what we'll often see is a variability in the markers. We may see cortisol levels start to slip. We may see norepinephrine levels not be as robust. In my experience, I have found that epinephrine tends to remain higher longer. Not necessarily, but I've just observed that a lot. So essentially, you're seeing some adaptations start to take place now. And then, of course, eventually in late stage or phase 3, the patient is pretty depleted. At this point, they're probably pretty exhausted. Cortisol levels are low. Epinephrine and norepinephrine are low. There are no hard and fast rules governing these changes, but you can see how the stages can sort of affect the dynamic changes seen with chronic stress. And you would probably choose very different treatments for this patient who's in depletion than the first patient we saw who had a lot of hypersecretion of these stress markers. Okay, moving on to glutamate. Glutamate is the most common excitatory neurotransmitter in the body. So here, if we look at the biochemical pathways, we see glutamate here. And the next one we're going to talk about is GABA. And you can see that they're just one enzymatic conversion apart. Glutamate, because it's excitatory, when present in excess, you can have sort of, symptoms of too much excitability. That might look like anxiety or insomnia or even an inability to concentrate. And then if glutamate is low, you would see the opposite, right? Not enough excitability. We might see depression, brain fog, fatigue, slowness. And here's some ideas about supporting it. All right, now GABA is the major inhibitory neurotransmitter. So this is where I sort of dork out on the beauty of the body, that glutamate is present as our primary excitatory neurotransmitter. And then one small enzymatic conversion turns it into our primary inhibitory neurotransmitter. Where glutamate is excitatory, GABA is inhibitory. It's relaxing and it's calming. So if GABA is low, we would see excitability, right? If GABA is elevated, we might see too much inhibition. One quick note about GABA. You may find GABA levels are elevated if there's a lot of excitability elsewhere. So if you test a patient and there's a lot of dopamine, there's a lot of norepinephrine, there's a lot of epinephrine, there's a lot of glutamate, you may see GABA elevated as well. This is the body's attempt to maintain homeostasis and try to provide the brake on the accelerator that is all that excitatory activity. And here's some ideas for addressing GABA. Histamine is not only responsible for the allergic response, it's also an excitatory neurotransmitter that's involved in the sleep-wake cycle and the inflammatory response. So it's got a couple of roles in the body. It's an immunomodulator that increases metabolism and promotes wakefulness and can suppress appetite. And its amino acid precursor is histidine. It's very involved in the sleep-wake cycle. If you've got a lot of histamine, your patients will have difficulty sleeping. So a way that I often will help patients understand this is if we think about the side effects of the first generation antihistamines, things like diphenhydramine. These did cross the blood-brain barrier, and so they would suppress histamine in the body, but also the brain, and so patients often feel sleepy when taking them. Some of the newer generations of antihistamines, things like Claritin and Zyrtec, they're designed not to cross the blood-brain barrier, which is why they don't cause as much drowsiness. So when it's low, we can see that drowsiness. We can see also changes in digestion and appetite control, and also issues with learning, memory, and mood. And if it's high, increased wakefulness and insomnia, as well as some, allergy-like stuff and gastrointestinal stuff. Now, I do want to say quickly that you might see high histamine in relation to an allergic response, but you probably will not, because histamine that's active in the bloodstream is metabolized so quickly that urine histamine testing is not the best way to evaluate for allergy symptoms. And to support histamine, again, some ideas here. The precursor, histidine, if it's low, but if it's high, here's some ideas about avoiding histamine-rich foods. A quick note here, diamine oxidase is the enzyme in our gut that is required to digest histamine. So sometimes giving this enzyme with meals can help. Some people don't want to stop eating histamine-rich foods, like fermented foods and cured foods in particular have high amounts of histamine. Whether or not they just love them, or maybe it's culturally important to them to eat them, you could try using diamine oxidase with those foods instead of having the patient remove them completely. Glycine is our next neurotransmitter. It is the second most widespread amino acid in the body. It's made in the liver, and it's found in all of our connective tissue. In the CNS, it's primarily found in the spinal column, but it's found in all connective tissues. So it's pretty ubiquitous. It's inhibitory. So after GABA, it's sort of the second most important inhibitory neurotransmitter. So again, if it's low, we may not be able to sleep, but it's because we've got a racing mind, because we don't have enough GABA to slow that activity. And then if we have too much glycine, again, we could kind of feel foggy. Now, glycine, here's some ideas for supporting low and high. A quick note, because glycine is so ubiquitous in connective tissues, bone broth is actually a great therapeutic option if you're trying to raise glycine, but also if you test a patient and you find high glycine, check their diet, because anything that comes from the boiling of bones, so it's gelatin or potentially collagen or bone broths, may be high in glycine. Okay, the last neurotransmitter we're going to discuss is phenethylamine, more commonly called PEA. This one you may be familiar with in terms of its association with ADHD. It's also considered to be excitatory. So in high amounts, we'll see some of these more, agitated, anxious type symptoms, and these are the issues associated with low PEA. Now, ADHD is interesting to consider here, because some research indicates that PEA could be considered a biomarker for diagnosing ADHD. So this was a study. They didn't find enough studies to do a meta-analysis, but they did find 3 studies that confirmed that urinary levels of PEA were significantly lower in patients with ADHD compared with controls. Now, interestingly, when they administered some of the typical ADHD medications that are excitatory, things like Ritalin and Adderall, that actually caused PEA levels to rise in these children. But more natural therapies can do it as well. Things like the amino acid precursor phenylalanine. But you can see here, the authors state urinary biogenic trace amine PEA levels could be a biomarker for the diagnosis of ADHD. And so here's some ideas for supporting low and high. And some references for you. Okay, so in addition to looking at individual imbalances when you're testing, you also want to consider, is the patient trending towards excitatory secretion or more inhibitory secretion? It's important to consider that. Now, the neurotransmitters that are considered to be excitatory are listed here, and inhibitory ones are listed here. Serotonin is listed with a little bit of a gap here. I don't consider serotonin to be inhibitory sort of in its own way, but it is a precursor to melatonin, so certainly can help with sleep, but it's definitely not excitatory. All right, now we're going to get into metabolism, sort of the last phase of the things that we can use or assess with neurotransmitter testing. So here we're looking at the monoamine oxidase that can, metabolize things like serotonin, and then the COMT, catechol-O-methyltransferase, that can metabolize the catecholamines. And the Comprehensive Neurotransmitter Profile allows you to get information on these metabolites, as well as some trace amines like tyramine and tryptamine and things like that. But really what we're interested in is, how are these enzymes that break down neurotransmitters, how are they functioning? So monoamine oxidase is often thought about because it breaks down serotonin, but it breaks down a lot of things, including catecholamines. It clips an oxygen off of an amine group, which inactivates these neurotransmitters. So it also can break down the neurotransmitters that are in food. So there's MAO active in our guts as well. So there's a lot of interesting research on MAO variants. This is just one study that I wanted to show that essentially showed that, there's different alleles, different genetic SNPs that can result in changes. But what I'm trying to show you here is that any variation, any SNP that results in a slowing of the enzyme will often result in higher levels of the neurotransmitter that it's metabolizing. So if we have slow MAO activity, we may find the patient has higher levels of serotonin and catecholamines. Whereas if any genetic SNPs result in a faster acting enzyme, we may find we have lower levels of those neurotransmitters. So MAO activity affects all of these markers. This is what it breaks down. And these are options for supporting MAO. Generally, we're thinking about the cofactors that fuel it, if it's sluggish, and if it's overactive because it is an oxidative enzyme, we consider antioxidants to try to control that. And we know that MAO, monoamine oxidase inhibitors, MAOIs, which are pharmaceuticals, can result in higher serotonin because they're slowing the activity of the enzyme. But St. John's wort can actually act as an MAOI. And when it comes to things that can slow MAO, tobacco and caffeine can. So that's why you might want to avoid them. And there's some other natural MAO inhibitors, and I listed those for you here. But St. John's wort it's the most well researched. And some references for you there. So the other enzyme that breaks down neurotransmitters is the catechol-O-methyltransferase, or COMT. So it degrades dopamine, epinephrine, and norepinephrine. It introduces a methyl group to the catecholamine, which is donated by SAM. So this is a methyl-dependent process. So people who have trouble methylating may have issues here. There have been some pharmaceutical COMT inhibitors that have been developed for use in Parkinson's, but there are some ways to address it with natural functions too, or natural support. So again, just like when we were talking about with MAO, if any sort of SNP results in the slowing of this enzyme, we can see an increase in catecholamines. generally that means more excitability. And if the enzyme is very, very efficient, working very quickly, it can deplete those catecholamines. So we would be secreting more of the metabolite. Then we would see too little excitatory activity. So COMT activity affects these markers. But let me go back really quickly. I do want to point this out. The degradation of dopamine, epinephrine, and norepinephrine is a two-step process. So you can see it requires both COMT and MAO. So that's important to remember because we often think about COMT as the enzyme that degrades catecholamines, but it actually also requires MAO. So if the COMT is sluggish, we would consider some of these cofactors, methyl support. Dietarily, we consider cruciferous veggies and things like that to support it. If it's overactive, we would probably choose to support the MAO enzyme. And why is that? Because it is a two-step process. So other factors to consider here, we don't have a lot of time left, but I did want to just mention that diet is so important because the brain's structure and function, including neurotransmitter secretion, requires amino acids, fats, vitamins, and minerals, and trace elements. So if we're eating a diet that's high in veggies and fruits and lean protein, because amino acids are found in all foods, but highest amounts in animal sources of proteins, then we usually see better outcomes, right? And also getting good fiber and getting good polyphenols and phytonutrients can help. And fish, because of that omega content, can decrease the risk of depression. The Mediterranean diet is a great example of a diet that sort of incorporates all of these good choices to help to manage our brain health and our symptoms. A quick note about diet and amino acids. So there are some people out there who propose that just changing our diet and eating foods that are higher in certain amino acids can actually help to correct neurotransmitter imbalances. And as a naturopathic physician, I think diet it's just paramount. It's so important. But most of us eat plenty of protein. So apart from your patients who are poorly practicing vegans and vegetarians who may be protein deprived, most of us eat enough protein-rich foods to supply all the amino acids we need to our neurotransmitters. So the issue may not be a lack of ingestion of the amino acids, but are they being absorbed and how are they being utilized, which is one reason why I think gastrointestinal testing is such an important test to consider with these patients. And when it comes to diet, I know it's kind of become the thing that makes people roll their eyes, but removing gluten can be very beneficial when people are sensitive to it, or even doing a trial in someone who claims to be able to tolerate it, but has issues with depression, anxiety, concentration, etc. Anyone who considers themselves to be neurodiverse will typically see some benefit from removing gluten because there's some studies that indicate that gluten sensitivity actually destroys the brain and nervous tissue more than any other tissue in the body, and that includes the gastrointestinal tract. We know that folks who have celiac disease are more likely to experience depression, anxiety, and thoughts of self-harm, in addition to a reduction in reaction times and cognitive function, and even neuroimaging can show changes in the white matter in the brain. So as much as I get eye rolls when I am talking to patients about it, doing a trial of no gluten is often a really helpful thing. When it comes to hormones, we know that in women especially, estradiol is important for secreting serotonin and dopamine. And in males, it's testosterone. Now, males need a little estrogen and females need a little testosterone, but largely those are the hormones that drive the secretion of these neurotransmitters in the various sexes. And then we also need appropriate amounts of thyroid hormone. So like I said, this is a urinary test. There are two options with doctor's data. So I want to take a moment to talk you through them so you can better determine which collection might be most appropriate for your patient. The 24-hour collection allows you to measure the average excretion of neurotransmitters over the course of a day, and it's reflective of the influences of food and stressors that your patient is experiencing in that time. Now, if your patient has kidney disease, this is the only viable option. And I do want to note that for anyone who's collecting, or anyone who's out there in the audience who has collected a 24-hour for a 24-hour test, you know that it's cumbersome. And it's really easy to miss a void. And if you miss even one void, the results will be skewed. So the other option to consider is spot testing. Spot testing generally is a first or second morning void and allows you to measure baseline neurotransmitter levels with less influence from the environmental stressors that the patient may face or from foods. It does correlate really well with 24-hour results, and it is the more convenient option due to the cumbersomeness of trying to collect every void over 24 hours, and then your patients don't have to cart around that big orange jug all day. So if you choose a spot test, you've got two options here, a first AM void or a second AM void. The second void was the industry standard for a long time, so a lot of providers are comfortable using this, but I think the first AM void now is considered to be very appropriate. It's just as reliable as the second, if not more so, because if you collect that first void right out of bed, you don't have time for the patient to get in a fight with their spouse, to try to get the kids out the door, to go to school, to have a cup of coffee, to smoke a cigarette, et cetera, et cetera. So all of those influences that can affect neurotransmitter secretion are avoided if you collect that first void. A common question we get is it okay to test patients who are on psychotropic medications, and how will these antidepressants affect the test results? So the answer is yes, you can. We don't recommend stopping medications for the purposes of testing. Generally, patients really rely on these medications. So what you do is you test them, and then you look at the results through the lens of the medication in question. Most of the time, patients are not tested before they're put on these medications. If you're lucky enough to have a baseline, you can see how the drug is affecting neurotransmitter secretion. But usually that's not the case. But we have observed that typically over time, drugs like SSRIs will deplete the neurotransmitters that they're dealing with. So an SSRI use for many months or years, depending on the patient's physiology and metabolism, will eventually deplete the neurotransmitter in question. Okay, I know there was a lot of information coming at you quickly, but I hope this overview has provided a good roadmap for you to think about optimizing neurotransmitter secretion and metabolism in your patients, because patients are complex and they'll often present with really similar symptoms. You know, the ones I typically see are fatigue, mood concerns, issues with focus and concentration, and insomnia. But the etiologies of these symptoms are complex and they can be really different in each case. So testing can allow you, the provider, to determine which therapeutics will be appropriate for your patient. All right, thanks so much for your attention. Angie, do we have time for questions?